Welcome back to Pharmacology for Vocational Nursing 2. This is week 4, and we are studying the antilipemic drugs. It's chapter 27 in your textbook. This slide presentation will be at least 2 audio lectures, so let's get started. So in order to understand the antilipemics, we have to think about the lipids, and the lipids are these fats. They're organic compounds, and they're essential for good health. We have 2 primary forms of lipids in the blood. We have the most common one, that's the triglycerides, and they're the major storage form of fat in the body, and the only type of lipid that serves as an energy source, an important energy source. They're about 90% of the total lipids in the body. Cholesterol is the other type of lipid that's a major component, but it's a major component of the cell membranes, and it serves as a building block for other lipid-based biochemicals like our vitamin D, our cortisol, our bile salts, estrogen, and testosterone. The negative role with cholesterol is that it promotes atherosclerosis, and we're going to talk about that in just a few minutes. So these water-insoluble fats then must be bound to the apolipoproteins. That's a specialized lipid-carrying protein, and lipoprotein is the combination of either the triglyceride with an apolipoprotein or cholesterol with an apolipoprotein. Let's go into a little bit further detail about these lipoproteins. So our very low density lipoprotein, our VLDL, is produced by the liver, and it's the primary carrier of the triglycerides in the blood. It's made by the liver and converted to LDL, or the low density protein, as it travels through the bloodstream, as most of the triglycerides in the VLDL are transported to adipose tissue for storage. The health consequences of high blood levels of the VLDL are not as clear as it is for the LDL, but we know that it transports the endogenous lipids into the cells. And we also know from the research that high levels of VLDL are often associated with an increased risk of pancreatitis. So if you were to draw a circle and split out the VLDL, what you would find in the center is 55 to 65% triglyceride, surrounded by about 15 to 20% of phospholipid, then 10 to 15% of cholesterol, surrounded by a 5 to 10% layer of protein. Our low-density lipoprotein is the greatest amount of the package lipoproteins. About 50% of the LDL consist of cholesterol. So again, if we were drawing a circle like we just did with our VLDL, the center of that 10% would be triglyceride, surrounded by a 20% layer of phospholipid with a 45% layer of cholesterol, and then a 25% layer of protein. Now, this low density lipoprotein, this LDL, is made in the liver, it's transported to the tissues and the organs, and there it's used to build plasma membranes or to synthesize other steroids. Once it's in the tissues, it can be stored for later use. Storage of the cholesterol, however, in the lining of the vessels contributes to plaque buildup, and that's what we call atherosclerosis. We'll talk about that in greater detail in just a minute, but let's talk for a second about the high-density lipoprotein. Now, the high-density lipoprotein, or the HDL, is also known as the good cholesterol. If we were drawing our circle, what we would find is in the center, we would have 5% as the triglyceride. We would have a 30% layer then of the phospholipid, a 20% layer of cholesterol, and a 45 to 50% layer of that protein. So what does it do? Well, the high-density lipoprotein actually picks up the cholesterol in the blood and the other tissues and returns it to the liver. Once it's in the liver, the cholesterol is used to make bile. Now, we know that bile is essential for the digestion of lipids, right? So the cholesterol component of bile is then actually excreted in the feces. Although some of it is reabsorbed back into the circulation, the excretion via the bile is the only route the body uses to remove cholesterol. So this high-density cholesterol, or good cholesterol, could be called the cholesterol scavenger because they go and pick it up in the blood and remove it from the body. Now we have to remember that cholesterol is not the only type of lipid that can lead to cardiovascular disease. Triglycerides have to be monitored and maintained as well, because if those go unchecked, we're going to have varying higher levels of our cholesterol. Let's look at what the cholesterol does in the body. So we know that cholesterol is, as it lines those tissues, or lines the cells of the vessels, we get an increase in atherosclerosis. Now, we want patients' levels to be less than 200 milligrams per deciliter of the cholesterol. When they have 200 and greater, they have a risk of coronary artery disease, and they have a risk of things like myocardial infarction. They have risk for angina. They'll have all kinds of problems with their circulation. Interesting, when we go from 200 to 300, once they hit 300, it's a 3 to 4 times greater risk of coronary artery disease than in the patients with a level that's less than 200. Sometimes you'll hear coronary artery disease referred to by its older name, CHD, which is coronary heart disease. So this atherosclerotic plaque formation occurs because the lipids and the lipoproteins form these plaques, and that's what leads to the development of the CAD. The serum cholesterol levels are elevated. The circulating monocytes then adhere to the smooth endothelial surfaces of the coronary vasculature. Macrophage cells are formed and they fill up with fat. So these foamy cells develop. They're the precursor to the atherosclerosis. You'll hear a couple of different terms. You'll hear the term dyslipidemia. Dyslipidemia is a general term that means there's an abnormal amount of lipids in the blood. Hyperlipidemia is a similar term that refers to high levels of lipids in the blood. And some patients may have only one specific type of lipid that is elevated. So it's really important when you're looking at labs to see what the elevation is. And the elevated blood cholesterol can also be called hypercholesterolemia. If it is cholesterol, but we may have hypertriglyceridemia, it's elevated triglycerides. It's actually a less common disorder. So how do we treat this? Well, hyperlipidemias are treated typically with the antilipemic drugs. They're drugs used to lower the lipid levels. It can also be used as an adjunct to diet therapy. And the drug choice is based on the specific lipid profile of the patient. Just like I was just saying, we want to look at the labs. It's going to have an HDL, an LDL, a VLDL, and a triglyceride. That's called phenotyping. So when we look at hyperlipidemia treatment and guidelines, really all reasonable non-drug means of controlling blood cholesterol levels should be tried for at least 6 months and found to fail before we start drug therapy. I say that tongue-in-cheek a little bit because if we have extremely high levels of triglycerides, we may not wait for diet and exercise to take effect. And the same thing with extremely high levels of cholesterol. So for example, if you have a patient's triglyceride levels that come back at 600, we need to do something sooner rather than 6 months from now. So when we look at these medications, we look at some subcategories. Our HMG-CoA reductase inhibitors, you will recognize these as statins. Bile acid sequestrants are vitamin B, niacin. Fibric acid derivatives, they're called fibrates. Cholesterol absorption inhibitor, and some combination drugs. If you look at the mind map that you have posted, you'll see these subcategories listed. I've also posted for you a little bit of a study guide on how to use that mind map baby in a better way, just in case some of you were struggling with it last week and didn't quite know what to do with it. Let's get started with the statins, or the HMG CoA reductase inhibitors, or you'll hear them HMGs. Most people just call them statins, because if you look at their suffix, they all end in statin, right? Pravastatin, simvastatin, atorvastatin, fluvastatin, rosuvastatin, pitavastatin, right? They are the most potent of our LDL reducers. So this is where it's important for you as a nurse to make sure that you're giving some patient education on the therapeutic lifestyle changes that need to occur. And we'll talk about those more at the end. But these are pretty strong medications. So how do they work? Well, they're reductase inhibitors, right? They inhibit this HMG-CoA reductase. So I'm just going to say it once for you. It's the hydroxymethylglutaril coenzyme A reductase. And what it is it serves as a primary regulator of cholesterol biosynthesis. Under normal conditions, this enzyme, right, is controlled through a negative feedback cycle. So high levels of LDL cholesterol in the blood will shut down the production of this reductase and turn off the cholesterol pathway. So what the statins do is they inhibit this reductase. So as the liver makes less cholesterol, the body responds by making more LDL receptors in order to scavenge more of the LDL from the blood, thus reducing the LDL blood levels. And in fact, the effect is ultimately that it lowers the rate of cholesterol production. So the problem is that the statins then act by inhibiting this enzyme. So as the liver makes less cholesterol, the body responds by making more LDL receptors, right? But the drop in the lipid levels isn't permanent. So these patients may need to remain on these drugs for the rest of their life, or until their hyperlipidemia can be controlled through those lifestyle changes. They have been shown, the statins have been shown to reduce the progression or slow the progression of coronary artery disease and reduce deaths from cardiovascular disease. Their indication is a first-line drug therapy for hypercholesterolemia. If we're treating depending on the type of hyperlipidemia, we will get reductions of 30 to 40%, increasing the HDL level by 2 to 15%, and reducing the triglycerides by 10 to 30%. Now remember, these are drug studies, but we also have to factor in lifestyle changes. That's incredibly important. Because of the way these drugs work, we need to make sure that we're monitoring the liver enzymes. So we will do liver enzymes before these medications are prescribed, typically. They will cause elevations in the liver enzymes or liver disease. They may have mild transient GI disturbances when they first start taking it, a rash, headache, myopathies, or muscle pain, possibly leading to a serious condition called rhabdomyolysis. Now, that being said, they're generally pretty safe. So we don't have high incidences of these serious side effects or adverse effects, but it is important that we monitor this. The rhabdomyolysis is this medical condition in which the muscle tissue, including cardiac muscle, becomes extremely inflamed, and it results in the breakdown of muscle. So the patient will report muscular soreness or weakness. They may need to have their statin dosage reduced, or they may need to be switched to a completely different drug class. There's a long list of interactions with our statins, oral anticoagulants, and drugs that are metabolized by the CYP3A4 in the liver. So look at that list quickly, and let's move over to the next audio lecture. See you soon.